Hi everyone, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I am a nurse here at UWorld. Thank you so much for tuning in today. So today, to go along with yesterday's antepartum disorder lecture, we're going to be doing an antepartum question drill. So if anyone joined yesterday, now is a great chance to test some of that knowledge. We're going to be doing our normal question drill format. So we're going to ask a question, give you about 30 seconds to answer. Reminder to drop those answers into the chat. We have the wonderful nurse and Coley moderating for us today. With that being said, follow us at UWorld Nursing. Go ahead and give this live a share and visit uworldnursing.com for our complete schedule of times, topics, and channels that we go live on. So with that being said, let's go ahead and get started today. Question number 1, we have a tough one out of the gate. So the nurse in the labor and delivery unit is reviewing fetal heart rate patterns for multiple clients. Which of the following patterns would be a priority to follow up? Our options are option 1, moderate variability with no accelerations, 2, minimal variability with a baseline rate of 115 beats a minute after receiving zolpidem, 3 is minimal variability with recurrent late decelerations, and 4, moderate variability with a baseline rate of 155 beats a minute after receiving penicillin. So go ahead, drop your answers in the chat. Again, which of the patterns are a priority to follow up, meaning which are we most concerned about? What of these options do you see? And maybe you get a little bit nervous, you start to sweat a little bit. This is the client we want to check on first. Drop those answers in the chat. Let us know what you all are thinking. Please also keep following us. We are now adding new live times, and you may miss out on some of these new times if you don't follow us to get hints and notifications on when we'll be going live. We've added those 7 p.m. live slots on both Wednesday and Friday. We're also considering a weekend live, so drop in the comments below if you would prefer to have a weekend live and let us know, is Saturday better or does Sunday work better? We're trying to hit all of y'all's schedules, which I know a lot of you guys work nights, some of you guys work days, you're in school, you're in the hospital, so we want to make sure we give you guys lots of different options to join our lives. Alrighty, lots of answers in the chat, and you guys are spot on. Option number 3 was our correct option, so way to go there. A couple of terms I want to go over. This question kind of threw a lot at you. So first and foremost, variability is going to be the fluctuation of that fetal heart rate. It can be moderate, minimal, marked, or absent. We want to see it in that moderate range. It's a reassuring sign. Now, accelerations are another reassuring sign. They're increases in that fetal heart rate above the baseline. So to know what an acceleration is, first we have to establish a baseline. Baseline fetal heart rate, a normal range is between 110 and 160 beats per minute. In clients that are 32 weeks at or over 32 weeks of gestation, an acceleration is going to be considered 15 beats over that baseline, sustained for 15 seconds. You may hear this referred to as a 15 by 15. And then those clients under 32 weeks of gestation, we're going to look for a 10 beats per minute elevation over the baseline that's sustained for 10 seconds, or a 10 by 10. So again, depending on gestational age, an acceleration will be 15 by 15 or 10 by 10. Now, late decelerations are not a reassuring sign. There's something we would be concerned about. It typically begins after the contraction starts, typically at the lowest point of the deceleration after the peak of the contraction. So late decelerations, again, are not a reassuring sign. They're actually going to be a sign of utero-placental insufficiency. The baby is not getting enough oxygen here. So again, for variability, we want to see moderate. So when we have minimal variability in option 3, that's a cause for concern, as are those recurrent late decelerations, which are a non-reassuring sign. So fetal heart rate tracings are divided into 3 categories. An easy way to remember it is category 1 is a reassuring pattern, category 3 is a non-reassuring pattern, and essentially category 2 is like a catch-all, everything essentially in the middle. So in this option 1, moderate variability with no accelerations, moderate variability is what we want to see. That's good. No accelerations we're not necessarily concerned about right now. This can mean the baby is in a fetal sleep cycle. In this case, we would keep an eye on it, look for it to perk back up. But if we have those periods of no accelerations, it most likely means that the fetus is just in a sleep cycle. Option 2, minimal variability with a baseline rate of 115 beats a minute after receiving zolpidem. Zolpidem is Ambien, that's the trade name. This is a sedative hypnotic. It's often given to laboring mothers in the early stages of labor. So especially if we have like inductions that come in, they need to get a good night's sleep before they have a big day, dilating and delivering that baby tomorrow. So we can see this to be, normal rate again is 110 to 160. So 115 we're not concerned about. We'll keep an eye on this baby, look for it to perk back up later, but this is not going to be our priority. Option 3 was our correct answer because we're worried about this. This is our priority. Minimal variability is non-reassuring. We want to see moderate, and recurrent late decelerations are also not reassuring. And lastly, that moderate variability with a baseline rate of 155, that's still within our normal 110 to 160 range. And penicillin is something we typically give as GBS prophylaxis or group B strep. Now, a lot of us are carriers for this. It doesn't pose much of a threat to a fully developed immune system of an adult, but it can pose a threat to the immature immune system of a fetus, which is why we're going to give prophylactic antibiotics, and penicillin is common to give for GBS in mothers without penicillin allergy. So again, our correct answer was option 3 because this is our priority. We are most concerned about this tracing. Alrighty, question 2. The nurse is assessing a client with suspected placental abruption. Which of the following findings would support a diagnosis of placental abruption? Is it that painless bright red vaginal bleeding, a rigid board-like abdomen, referred shoulder pain, or uterine atony? Drop those answers in the chats. Alrighty. Also, I keep seeing people commenting on what days would be great. A lot of you guys said Saturday. That actually surprises me. I don't know why I thought Sundays would be better, but we will take that feedback into account. Thank you so much for submitting it. We really appreciate it. Also, let us know who here has taken their NCLEX and passed. Let us know so we can congratulate you. Who here is about to test so we can wish you good luck. We are entering a pretty busy, pretty hectic testing season. Late May, June, July is when we see a lot of people taking that NCLEX, especially for our spring graduates. So let us know when you're testing, if you've already tested. I see Maddie is testing on June 3rd. Good luck. You're going to do great. You're in the right place. Clearly, you're preparing hard. Someone tests on Friday. That's Lauren. Good luck. Coming up, you're going to do great. Alrighty, so lots of answers coming in. It looks like the majority of you guys got the root of this problem, and that's going to be option 2. So, let me go back to the slide, sorry. So we're looking at placental abruption, which is the separation of the placenta from the uterine wall. The symptoms can vary depending on the severity of the abruption. There can be a full abruption, meaning it completely peels off that wall, or it can also be partial. We can also just see like the edges peel off. It doesn't have to be all or nothing. So you'll often see vaginal bleeding with placental abruption. However, it's typically not going to be painless. So we can knock option 1 out of the running. Other symptoms of placental abruption will be uterine tenderness. We can have abdominal pain, but again, that bleeding is going to come along with some painful symptoms. It typically won't be painless bleeding. So option 1 is incorrect. 2 is our correct answer. That rigid board-like abdomen is a hallmark sign of placental abruption. So we want to make sure when we see that board-like abdomen, I want a little alarm to go off in your heads to start thinking about placental abruption. Alrighty, option number 3. So we have referred shoulder pain. This can be a sign of a ruptured ectopic pregnancy. It can also be a sign of referred gas pain, but it's not typically a clinical sign of abruption. Lastly, option 4 is uterine atony. We typically see the opposite with placental abruption. So we'll see uterine hypertonicity, a supertoned uterus, not atony, which indicates the lack of tone. Because when the placenta abrupts here, it peels off, that uterus contracts, it tries to clamp off the bleeding, meaning it's hypertoned, not lacking tone. So again, our correct option is option number 2. Way to go. Alrighty, question 3. The nurse is reviewing new prescriptions for a client who is scheduled for induction of labor. The client has a history of previous cesarean birth and a positive test result for group B strep. Which of the following prescriptions should the nurse clarify? Is it oxytocin, ampicillin, misoprostol, or nalbuphine hydrochloride? We need to get in some of that Jeopardy music for the background. And lots of testers too. I see people testing tomorrow. Good luck. Someone is testing at the end of next month, and I see an August 4th. So August 4th, you are way ahead of the curve. That isn't Nursing Coley's birthday, so I think that's a good luck charm. Alrighty, and it's also President Obama's birthday too, right? Yeah. So I think that's pretty good luck. And Meghan Markle. I I see someone asking what uterine atony is, just a lack of tone to the uterus. Remember, when we have babies, when we're in labor, that uterus contracts. You have contractions. It's kind of like the same premise. After we give birth, that uterus needs to contract and be nice and toned to help clamp off the bleeding so we don't have a hemorrhage. So we're talking about uterine atony means we're lacking that tone. We're lacking the uterine tonicity. Alrighty, great job, you guys. I'll let a couple more people answer. I see lots of good ones coming in. Alrighty, and a reminder to share and follow if you haven't already. Alrighty, and it looks like the majority of you guys got the correct option. That was option number 3, or misoprostol. So why was this? This client is looking to VBAC. We see they clearly had their schedule for an induction of labor, but they've had a previous cesarean birth, and it lets us know that they're GBS positive. So VBAC means a vaginal birth after a cesarean section, meaning a client who's had a previous C-section is now looking to have a vaginal delivery. So previous C-section clients are actually going to be contraindicated for misoprostol. What misoprostol is the trade name is Cytotec. It's a cervical ripening agent that's used to ripen the cervix before we induce with a Pitocin or an oxytocin. What it does is help to stimulate contractions to dilate and efface that cervix and make some progression so we can further induce labor. In this case, misoprostol will be contraindicated in clients with previous C-section because it increases the risk for uterine rupture with clients who have prior uterine incision, such as a C-section. This is the prescription that we would clarify because it's unsafe to give. So misoprostol was our correct answer. 1, 2, and 4 are going to be A-okay for this client. We don't need to clarify. So 1 is going to be oxytocin. Now this is something that does induce labor. Misoprostol ripens the cervix. Oxytocin induces labor. So there's a little bit of a difference there. A lot of times people just use induction as kind of like a blanket term when there's actually some specificity to it. The reason we can give oxytocin in a previous C-section client is that we can titrate it. It's given via IV. So we can stop the IV, we can turn it down if needed, we can turn it up if needed. In misoprostol, this is given via a vaginal pill or an oral pill. Once we give that, we can't really take it back. And that's why it's unsafe to give that for a C-section client, whereas an oxytocin, because we can titrate it, we're able to give this. So this would not be contraindicated. We would give this to augment labor. Option 3, ampicillin, is just an antibiotic. This is often prescribed for the treatment of GBS. We definitely want to make sure we give prophylaxis for GBS, or if we don't know the GBS status, and we always give that antibiotic for positive test results for GBS. Again, that group B strep doesn't pose much of a threat to the adult fully developed immune system, but for a newborn's immune system, it could. So that's why we're going to give that prophylactic antibiotic. And lastly, option 4 is nalbuphine hydrochloride. The trade name for this is Nubain. This is an analgesic. It's a synthetic opioid. We can also give it post C-section to help with some of that itching that results from those spinal and epidural medications. So again, 1, 2, and 4 were A-okay to give. Option 3 would need to be clarified. It's unsafe. Alrighty. Someone says maternal meds are not my favorite. No worries, you're in the right place. We're going to go over them in full. So question 4 is the nurse is planning care for a client who is pregnant and has severe preeclampsia. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. So option 1, administer labetalol. 2 is that carboprost. 3 is check our DTRs. 4, we want to administer mag sulfate. And lastly, 5 is minimize environmental stimuli. We did a antepartum disorder lecture yesterday, and we covered this question. We talked a lot about the hypertensive disorders of pregnancy. So if anyone joined us for that, let us know in the comments, let us know in the chat. You have a secret, heads up because we did this question yesterday. I see Maddie says Cytotec is a high risk for rupture. You got it. Way to go. Alrighty. And special bonus question, when we have too frequent of a contraction pattern, especially after we've given a Cytotec in a client, what medication are we gonna give? So when the client contracts too frequently, we're not able to quell it with non-pharmacological interventions, what medication will we do or give to cease contractions or try to stop contraction activity? It's a tough one, but I think you guys got it. Someone said MAG. That's not quite right, but that is a maternal medication, so I guess you're in the right vein. Terbutaline, Felix got it. Way to go. We are going to give some Terb. So we're going to give this via a sub-Q shot for a client that is having too frequent of a contraction pattern, which is more than 5 contractions in 10 minutes. Alrighty. Ooh, I like that. Stop contraction action. Alrighty, so I see lots of answers coming in. You guys got this one. We are talking about our preeclampsia nursing interventions. What we're going to do is 1, 3, 4, and 5. So severe preeclampsia is a hypertensive disorder of pregnancy with the element of protein in the urine. Now, we can have preeclampsia with or without severe features. Obviously, with severe features is going to be a more higher acuity disorder. So in this case, option 1, administer labetalol. It's a hypertensive disorder. We see those high blood pressures. Labetalol is a beta blocker. It's an antihypertensive to decrease our blood pressure. Labetalol is safe to give during pregnancy. It can go oral or IV. We can also give a calcium channel blocker like a nifedipine or a Procardia. Fun fact, that can also help us to cease contraction action, so to speak. In this case, we're never going to give ACE inhibitors, which are another type of antihypertensive. Those are contraindicated in pregnancy. But labetalol, beta blocker, we're good to go. Help to decrease our blood pressure here. Option 2 is administer carbaprost. This is Hemabate, is the trade name. This is typically given in a postpartum setting when there's excessive bleeding to help that uterus contract, clamp off the bleeding so we don't hemorrhage. We would not give this in an antepartum setting while the client is still pregnant. So this would be incorrect. It's not indicated in the disorder of preeclampsia. 3, 4, and 5 are also correct options. So we want to make sure we check those DTRs for 2 reasons here. Brisk DTRs can be an impending sign of a seizure. We want to make sure those hyperreflexivity is a sign this client might be at risk of seizing. And on the flip side, when we administer MAG, MAG can be a depressant. It can depress our respiratory system, and a key sign that the client is becoming MAG toxic are depressed reflexes. So we want to make sure we're closely checking those DTRs, making sure they're not too brisk or could be a risk of seizing, and they're not too depressed, meaning they could be a risk of MAG toxicity. So we're looking at both ends of the spectrum. Option 4, I kind of gave this one away, but we also want to administer MAG sulfate. This works as seizure prophylaxis. It's a common treatment for severe preeclampsia. In severe cases, a client is going to be induced or delivered via C-section, and this client will stay on their MAG sulfate drip until 24 hours post-delivery. Lastly is option number 5, minimize environmental stimuli. This goes along with those seizure precautions. Now, preeclampsia is the precursor to eclamptic activity, which is seizure activity. So of course we want to enact our seizure precautions, making sure we have anything out of the bed that could injure the client if they were to seize. There's not any restrictive clothing. If the client is to seize, we never put anything in their mouth. And we also want to make sure we minimize those environmental stimuli. So loud music, loud TVs, maybe loud family members we also want to give or to remove from the room. Alrighty, someone says calcium channel blockers are not allowed to give for the pregnant patient. We do give nifedipine, which is Procardia. So that one would be okay, and that is a calcium channel blocker. So maybe not all calcium channel blockers, but nifedipine would be okay to give. And I see beta blockers are also good. Felix, you are on your game today. Way to go. Alrighty, someone asked again, nifedipine is a calcium channel blocker. That is going to be Procardia as the trade name. This is safe to give in pregnancy. Alrighty. Let me move on to our next question. Question 5. The nurses taught a client who is entering the 3rd trimester of pregnancy, which of the following statements would indicate a correct understanding of the teaching. Select all that apply. So first, via fetal movement is expected to decrease towards the end of pregnancy. 2, lightning makes it easier to breathe, but can cause increased bladder pressure. 3, spontaneous rupture of membranes, or SROM, can cause a large gush or a slow trickle of fluid. 4 is true labor occurs when regular contractions cause progressive dilation of the cervix. And lastly, 5, blurry vision and a severe headache are common discomforts of pregnancy. Someone asking about nothing in the mouth for seizure. We do not put anything in the mouth for seizure. There's a risk of aspiration. It could be broken off and swallowed. So we don't want to do this. Another person asking, why is carbaprost wrong? Again, that's Hemabate. That's going to be a medication we give to help stop bleeding in the case of a postpartum hemorrhage. It's not something we give in an antepartum setting for a preeclamptic patient. Alrighty, lots of great questions today. Way to go. Alrighty, great answers coming in. Just so you guys know, we have a free trial still available. So if anyone is joining our live, maybe weighing their test preparation options, we have a great 7-day free trial. Go ahead and check that out. You can find it at uworldnursing.com. It's a great way to get acquainted with our product before you purchase, so you can see how wonderful it is. Alrighty, great job, you guys. It looks like you all are doing well. Our correct option here is going to be a couple of them. We have 2, 3, and 4. So why was this? So option 2, 3, and 4 were our correct answers. Lightning is when the fetus begins to drop down in the pelvis. It essentially means that the body is preparing for impending birth. It relieves some of the pressure up higher on our lungs, on our diaphragm, makes it a little bit easier to breathe. But as it descends, it does put more pressure on our bladder, which can cause discomfort. This is a true statement. 3, spontaneous rupture of membranes, or SROM, can be a large gush or a slow trickle of fluid. Also true. This reflects the correct understanding of the teaching. It's not always going to be that, movie kind of big, huge gush. A lot of times it is actually a slower trickle. Lastly, 4, true labor occurs when regular contractions cause progressive dilation of the cervix. This is true. This is what separates true labor from Braxton Hicks contractions, which is false labor. We do not consider it labor unless we're seeing that dilation, that progression of dilation and effacement of the cervix. So in this case, unless you are making progress, it's not true labor. 1 and 5 were incorrect. So why was this? Fetal movement is expected to decrease towards the end of pregnancy. This should absolutely not decrease. This is a cause for concern and a need to go in, notify your healthcare provider, go into your triage of your local L&D units. We want to make sure we're keeping an eye on those fetal kit counts. If they're decreasing, this is a cause for concern, not a reassuring sign. This is an incorrect understanding of the teaching. And lastly, 5, another incorrect understanding. Blurry vision and severe headaches are signs and symptoms of preeclampsia. They're not common discomforts of pregnancy. A client should not dismiss this as normal. They should go and seek medical attention and let their provider know. But way to go, you guys. You did so well today. Alrighty, great job. Question number 6, we're doing great. The nurse is screening clients for those at risk for experiencing a preterm birth. The nurse should recognize the client at highest risk for preterm birth is a client who, 1, stopped smoking 5 years ago, 2, had a previous vaginal birth at 38 weeks gestation, 3, has a pre-pregnancy BMI of 25 in a single gestation pregnancy, or 4, started receiving prenatal care in the 3rd trimester and has BV or bacterial vaginosis. Drop those answers in the chat. Let us know what you guys are thinking. Also, let us know, how are you guys studying? Are you using UWorld? Are you using a different question bank? Maybe you're using a live review, flashcards. Let us know the best way that you guys have studied. We're always so curious to see. I see a split. I see lots of UWorld. Nightingale, way to go. Another UWorld. Sunshine is using UWorld. Of course she is, or he. Alrighty, and I see lots of great answers coming in. Way to go, you guys. Also love to see all of our UWorld users. So in this case, our correct option was going to be option number 4. So let's talk about those risk factors for preterm birth. Remember, preterm birth is anything prior to 37 weeks gestation. Once you hit 37, we consider that to be term. So history of a previous preterm birth would put you at a higher risk for having another preterm birth in the future, as well as any infection of the genitals or reproductive tract, which includes UTIs or urinary tract infection, BVs, as we mentioned here in option 4, as well as those sexually transmitted infections or STIs. Multiple gestation also predisposes you to preterm birth. That means those twins, maybe triplets, so on, if you can imagine. Cigarette smoking will also be another risk factor, as is a late entry into prenatal care. So option 1, this client stopped smoking cigarettes 5 years ago. Smoking is a risk factor for preterm birth, but they stopped smoking 5 years ago, so they're not going to be our highest risk client. 2 is a previous vag birth at 38 weeks. 38 weeks is term, that's not preterm, so it doesn't predispose us for the risk of having a future preterm birth. A pre-pregnancy BMI in option 3, and single gestation. Again, multiple gestation is a risk factor, single is not, and this BMI is still within our normal range. Lastly, option 4, late entry. So they started receiving prenatal care in the 3rd trimester, which is late. We established care ideally in the 1st trimester, and they have BV, which is an infection of the vagina or the reproductive system. These are 2 different risk factors for preterm birth, so this would be our correct answer. Way to go, you guys. Alrighty, so lastly, we have the nurse is reviewing new medication prescriptions for a client at 29 weeks of gestation who is experiencing preterm labor. The nurse should clarify the prescription for mag sulfate, betamethasone, indomethacin, or doxycycline. Doing great, you guys. Another maternal medication question. I know someone said they struggle with this, but all the more reason to study it and practice it a little bit more. Keep letting us know what topics you all want to see. Maybe we should add a maternal pharmacology one to our list of question drills, but keep letting us know the topics you want to see us present on. We really try and hit on the things that you guys want to see more information, more resources on, so let us know what those are. Alrighty, I see lots of great answers coming in. You guys cannot be fooled today. Some of you guys even know what the side effects of these medications that are contraindicated are, so great job. Someone asked, is this an RN or a PN review? This is RN geared, but we do have PN materials available at UWorld. Psych was one of our recommendations. We definitely will work that in, mental health and those psych topics. That's a great recommendation. Thank you so much. That was a user on Instagram. And another psych from Instagram. Alrighty. Wonderful, you guys. It looks like the majority of you guys got the correct option, and that was option 4, doxycycline. So let's walk through this. We have a client at 29 weeks gestation. That is early. Remember, we're trying to get to 40 weeks. 37 and above is considered term. At 29 weeks, this is a pretty uncooked little fetus. We're ideally going to try to keep them pregnant. We're going to try and cease this preterm labor, but in some cases we are not able to do that. If the client's body is set on giving birth, it's going to give birth. So we'll do all our interventions, but sometimes we're not able to cease preterm labor. So in this case, mag sulfate is indicated. We would not need to clarify the prescription. It's indicated for preterm labor. It's a depressant that acts on the CNS or the central nervous system. It helps to relax smooth muscle. It's safe for use. We want to relax that uterine smooth muscle to cease contraction activity and hopefully keep this client pregnant for later than just 29 weeks of gestation. It's also indicated for seizure prophylaxis in preeclamptic patients, but in preterm labor, we give it as neuroprophylaxis. It's going to help to be preventative of things like cerebral palsy. It's neuroprotective was the word I was looking for. Alrighty, option 2, betamethasone. This is a steroid shot. It helps those fetal lungs to develop. We give this in 2 doses to the maternal client while they're still pregnant. Ideally, we're going to give it 2 doses 24 hours apart. Sometimes preterm labor progresses too quickly for us to do that. In this case, the provider will call it, say, let's give it 12 hours apart, or let's give it as far apart as time is going to permit. But in this case, we would give it via IM shot. And again, ideally, we're doing it 24 hours apart, 2 separate doses. Lastly, we have indomethacin. Now, this is an NSAID. It helps to prevent prostaglandin production, which helps to relax the smooth muscle of that uterus. Again, cease contraction activity. We want to keep this client pregnant as long as we can. It's indicated for preterm labor, and it's safe for use under 32 weeks of gestation. Lastly, we have our correct option because it's an incorrect medication. It's unsafe for the clients. This is doxycycline, which is a tetracycline antibiotic. It's a teratogen. We do not give this to a pregnant client at any gestational age. It can cause staining of the fetal teeth. I see someone said yellow teeth in the comments. You're absolutely right. It can also cause impaired development of those fetal long bones. So we're not going to give any tetracycline antibiotics. We're definitely not going to give doxycycline. Option 4 was our correct option because it's our incorrect medication that we need to clarify. So great job today, you guys. You did so well. Again, let us know how many questions out of 7 you all got correct today. It looks like we had a lot of people that did really, really well on our questions. We're going to be back tonight at 7 p.m. with Nurse Andrew. So make sure you guys tune in for that, and I hope to see you soon.